I will start with the case. This is a 24 years old male with medial knee pain. He got varus of the lower limb. The measurement here show that everything is mostly in the tibia, and so the intended correction, if I was not to do a PSI, would have been this 10-degree correction on the metaphyseal tibia. Lucky me, because of PSI, we learned how to do 3D plannings, and this brought us to new understandings of bone morphology that were published recently in several journals. And in this case, particularly, we have this 10 degrees varus on the metaphyseal tibia, but also we have this slope abnormality and this torsion of the lower tibia that we decide to correct. Free planar osteotomies. The free planning also give us the ideal cut to be performed, and also give us the size of the screw, the maximum length of the saw blade to cut before cutting completely the tibia and being in a neurovascular zone. And this is what happened to this young guy. He's pretty happy and asking me for the other side today. I use an extra staple to stabilize the osteotomy, because to do the rotation we are completely cutting the hinge, and I like to have a double control of the bone cut when the hinge is completely broken. So to me, the success of HTO is based on three main things. Indication, of course, is the main 30% of the job. The planning and the correction to be done is 20%, and then when you go to the OR, the 50 remaining percent need to be correctly achieved. And this is why PSI is, in my mind, something that will help surgeon to drive patient from point A to point Z without having big problems of correction and precision. This is a drawing for Christian Clay. First, you need to understand that indication is based on a metaphyseal substantial varus in the tibia or in the femur. And if you try to correct the bone at the varus at the wrong bone location, which is very important, this is what will happen. You will have this, for example, patient with global alignment in varus, but most of the deformity is in the tibia or in the femur or intra-articular, and the correction that have been performed lead the patient to a very big joint line obliquity, which will be, I think, detrimental in the next years of his life. What will be nice when using a PSI? This was the question we asked with Sebastian Parat in 2014. Of course, it should be smart and easy, accurate, provide us safety, give us some time sparing, and probably help us to do additional procedure when doing osteotomies. The first thing that we discovered doing PSI was that it was helping us to define clearly the sewing plane. If you change a sewing plane by 15 degrees around the clock compared to the mechanical axis of the tibia on a surgical plane, for example here, you will changing your slope by 1 degree every 10 degrees of rotation. The second point, which is very important to avoid any slope change, is to define a correct hinge position. And if you want to correct the slope, you need to, for example, if you want to increase the slope, you need to have an anterior hinge. If you want to reverse the slope, you need to have a posterior hinge, which is, of course, obvious, but it's not so easy when just defining this point with a saw. And if you think about this, you can also ask how to correct slope and to change slope with a single plane cut. We are now playing a lot with that, with patients with excessive or reverse slope to be corrected. How it works, basically, in 2015 we started using this PSI, which was the initial form of it, and you can see here you get two key wires that drive first the cut, second protect the hinge. Then you have some holes to be drilled inside of the PSI, and when you finish the job, the hole will not match with the final plate, the nuclear plate you have here. And the reason why is that the correction need to be performed before the hole will be facing each other's, and this is the beauty of the system. The correction is integrated in between those two maps, the hole you drill in the PSI and the hole you drill in your hole you have in a plate. It's also smart because it's giving you the depth of the blade to be used to do the cut until you just cut the hinge. It's an easy thing. We published this I think this interesting paper on the learning curve, and you can see after only 10 use, the number of X-rays, the time, and the stress of the surgeon is decreasing a lot. It's very accurate. We published this result in vivo on our first 100 cases. It's something around 1 degree precision on the tibia and 2 degree precision on a global lowering axis. There is a series integrating this patient from the French Arthroscopy Society that was published last week, confirming that this precision is better than navigation or freehand techniques. It's safe. We only have some infracture at the initial phase of the use because we were not using the protective key wire in the initial patients, and we have some 30%, 25 to 30% Takeshi-1 fractures that was confirmed on CT scans and on X-rays. Takeshi fracture is Takeshi 3-2-on-1 fracture are cumbersome when you do some osteotomies, and I think we find a way to protect the patient from that, having those key wire intersecting the bone at the medial aspect of the tibia and protect. Something else to said, we just move a little bit further with this hinge key wire protection. We have now putting some screws to protect the hinge. I was happy to see that some Australian surgeon used my technique too, our technique with Sébastien Parat and Nuclip to protect their tibia. Even I think this one is a cadaveric knee. We published this already in 2 journals, and to move forward, I would say that of course this PSI concept will help you to have some time sparing, because everything is pre-measured, pre-done, and registered in the planning. You can have some additional procedure with, for example, ACL surgery, that with the tunnel plan on the osteotomy here to be done and to avoid any contact in between the screws and the ACL tunnels. We published this in arthroscopy last month with Adrian Wilson and Christian Clay and Rabbi Kaka, which are working with me on science surrounding osteotomy. Femoral specificity, not a big deal. The plate exists, so the correction will be exactly the same. Once again, we are using this screw protection to avoid secondary fractures. Some paper that have been published by us or surrounding teams on the subject some in the last years. I can tell you that since my first use 3 years ago, in 2016, we have been doing but more and more complex cases with, for example, this 17-degree correction plus 5 degrees correction plus 20-degree torsion correction in a post-traumatic setting. This is what the guide looks like in this kind of cases: double anterior biplanar cut, a single horizontal cut to perform at the same time slope correction, rotational correction, and frontal correction. This is the X-rays this patient was operated on last week. A very small cutting guide. Finally, some take-home messages. You need to remember that this PSI system only helps your hands. It's of course something which is easy to have, but the correction to be done need to be decided accurately based on preoperative X-rays. It will give you some time, so it will give you some money. Even if there is an extra cost in the PSI, you decrease the timing of the surgery by 20 to 25 minutes, which is a lot in terms of money and room occupancy. There is, I think, no way back, specifically in complex cases, and it's more than a patient-specific; it's a surgeon-specific instrument. By using PSI, you will want to change something, having more screws, less screws, more hinge protection, more key wires, and everything is doable based on what you want with the society you're working with. Thank you for attention.